Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
Join us today for all things ocular oncology and uveal melanoma with two experts in the field, Dr. Lauren Dalvin and Dr. Basil Williams.
Dr. Basil Williams is Vice Chair, Associate Residency Program Director, and Associate Professor of Ophthalmology at Bascom Palmer Eye Institute in Miami, Florida. He is the current chair of the National Medical Association Ophthalmology Section and serves on the executive board of the Miami Ophthalmological Society, the Florida Society of Ophthalmology, the Pan American Ocular Oncology Society, and the Witt-Buckle Society. Dr. William also serves on the section leader of the ocular pathology for the American Academy of Ophthalmology One Network and the assistant editor of the oncology section of the Retina Atlas for the American Society of Retinal Specialists. His research interests include health equity, vitreoretinal surgical topics, and adult and pediatric surface and ocular tumors.
And Dr. Lauren Dalvin is an ocular oncologist and associate professor of ophthalmology with joint appointments in medical oncology and pediatric and adolescent medicine at Mayo Clinic here in Minnesota. She has over 175 peer-reviewed publications and was awarded a KL2 grant to support her patient-derived organoid-driven drug discovery efforts for uveal melanoma. She has National Cancer Institute and Department of Defense funding for Trichu model radiation retinopathy research. She has current or past leadership positions in the International Society of Ocular Oncology, the American Association of Ophthalmic Oncologists and Pathologists, and the Association for Research in Vision and Ophthalmology. Dr. Dalvin is passionate about multidisciplinary team-based eye cancer care and advancing the field through quality clinical and translational research. We're so excited to have these two powerhouses here. Welcome, Dr. Dalvin and Dr. Williams.
Thanks so much. Really appreciate being here.
Very excited, and especially excited that I get to do this with my friend and former co-fellow.
Yes, you guys are leading the future of ocular oncology, and you train together, you work together, and I wanted to bring both of you here to kind of give our audience everything you need to know, updates about ocular oncology, specifically uveal melanoma. You're both absolute experts, and so it's just fantastic to have you both here.
Yeah, I agree. Oftentimes we have one host at a time. Having two powerhouses in the studio at this time is a neat thing. I am excited about this opportunity. I have a family member that has gone through a recent uveal melanoma care scenario, and I'm excited to just hear from both of you about this field. Tell us about your journey, and maybe Basil, you go first, in terms of through training and your career. Why oncology, and what excites you to care for patients with uveal melanoma?
Yeah, so I must admit, I think I have a pretty atypical journey into ocular oncology. I actually knew before medical school that I wanted to do both retina and oncology. After college, I did not have a plan to go to medical school. I wasn't really thinking about that at the time, and I was just doing a stopgap, working in an office for an ophthalmologist because a friend told me that they needed some help. And while I was applying for finance jobs, an ophthalmologist was looking for some help in the clinic. So I worked there for a little while, and a couple of things happened over that time. One particular incident, there was a young patient. She was maybe around 18 or 19, and she had a large uveal melanoma that required enucleation. I didn't know at the time how rare that was. But I kind of saw the interaction between the physician and her family. And it really was remarkable how much of an impact and an opportunity he had to help, not only in that time that was scary for eye removal and thinking about her lifespan, especially at such a young age, but it was really the counseling and the way the family gravitated towards him and the clinic. And they even reached out to me a few times to ask me some questions. And I was thinking, I'm a technician at this point. I have very little knowledge in this. I've only been working in the office for a few days. But the dynamic there really gave me the opportunity to think about having an impact on families. And that really carried with me. And that kind of made the difference. And then ever since then, at every step, I've done research with someone and they've always done ocular oncology, and that's kind of been by happenstance. And so it kind of seemed like that was the right path for me. And there's a million reasons why I think oncology is the perfect field, at least for me. But I think that initial interaction where you were able to see somebody kind of dealing with something that was a life or death thing, but at the same time, the physician had compassion, was able to explain it, was able to build a relationship with the patient and their family. And that really, really struck me as having an opportunity to make a difference in someone's life. And so I think that was the initial spark for me.
I've said it before and I'll say it again, but I love hearing these journeys and stories about how people ended up in their subspecialty in medicine and how often serendipity plays a role and how we're led by these experiences. Like one of the formative patient moments was a uveal melanoma patient for you and the first patient you saw. It's just amazing how we end up, and you hear these over and over. It always kind of sticks with me. That's so fantastic. Dr. Dalvin, will you share your story? How did you get to ocular oncology?
Absolutely. I think you really hit the nail on the head. We just get led into these paths, and it's amazing how that happens. So I've told my story before in a few different platforms, but I went into not even just med school, but undergrad, knowing for sure I was going to be a vitreoretinal surgeon. And so when I matched into residency here, a mentor of mine in Ohio said, you have to work with Jose Polito. So I was terrified. I approached him, and actually I sort of chickened out for a year and had to reapproach him later the next year. But eventually I did some research with him, and I didn't know ocular oncology existed until I worked with him. But he really led me into my initial interest there. And then it was exactly a patient encounter that really solidified why I needed to go into this field. And I remember very vividly, it was a young woman who was pregnant who was diagnosed with a uveal melanoma. She was well educated. She had read all of the terrifying statistics that you see on the internet about this disease. And she was just sobbing, thinking, am I going to see my child grow up? And Jose looked at her, he looked at me at the back of the room and said, we're going to take care of this, and in 15 years, you're going to be seeing Dr. Dalvin, and she's going to tell you you're cancer-free. And at that moment, I knew I had to do this, and I knew I really wanted to do it here.
Wow, that gives me chills.
It's amazing. Most of us have stories in ophthalmology that talk about the beauty of the eye and the appreciation of vision. You look at the iris, you look at the retina, and yet I think for most of us, when you look into such a beautiful structure that we expect to be a critical vision providing resource for the body, and you see a tumor, you see a melanoma, it just makes us curl, it makes us uncomfortable, you mourn not just about the eye health, but about what this means for the body. So tell us a little more, each of you, about what excites you about dealing with such a devastating, challenging, disruptive diagnosis that would otherwise make most ophthalmologists say, I need to send you elsewhere.
Well, I suppose I can take a stab at that. You know, I think there's a couple of things that come to my mind when I think about melanoma. First, I think about the patient experience. They hear the word cancer, and sometimes they don't hear very much after that. And they start going through their mind thinking about, as Lauren had mentioned, they're thinking about their family. They're thinking about their future life. They're thinking about what opportunities they'll have to experience things that they want to experience, whether they'll be able to be there for their family and various other things. And one of the most important things to me on a personal level is to be able to connect with my patients. And I'm not sure that I'm gifted at very many things, but I like having the opportunity to talk with people, especially through difficult conversations. I like to listen to what they have to say. I like to try and understand and put myself in their position. And I like to try and work with them through that process. And I feel that one of the skills that I have is being able to understand and relate to people. And I think that's critical for this kind of situation. And I think I've seen many, many ocular oncologists, and a lot of them have this skill of being able to relate to the patient, and that puts them at some level of ease that's beyond the scientific and medical component of the process. And so I think that's one of the things that kind of drew me to this, is being able to identify someone in a time of need and walk them through that journey. There are so many things about the medical and scientific component of it that's intellectually stimulating, especially with some of the interesting ideas and technology and developments that are happening now and will continue to happen in the future. But I think it was really that personal connection that drew me in to begin with.
I completely agree. That's such a huge component of it. And I know I probably spend some of the longest periods of time with patients that people do in our department, but I could spend over an hour with someone who needs to cry, who needs a hug, and I want to be there for them in that moment. That's so important to me. And my patients are so grateful for having someone to listen and explain and talk them through and hold their hand through such a difficult time in their life. And it's so nice that it's not just that one-time encounter or a one-time surgery, but I continue to see these patients for years and years and years, and I see their families grow up. It's really meaningful to me. And I think the other aspect that really drew me to this field is I see such an opportunity to advance and do better for these patients. I say it all the time when I talk about the research that I do in the lab, but my patients drive me to find cures for this cancer. I want to get to a point where at the end of my career, instead of patients looking at me with fear that we're just waiting for the other shoe to drop on a scan, that I know if we get a scan that has bad news, I'm going to have a treatment for them that works. And so by the time I retire, I hope we have a much different story for this disease.
I love hearing your stories. And like you were saying, Dr. Dalvin, let's kind of dive into the diagnosis and treatment of uveal melanoma specifically. It's a passion for both of you. How are we doing with diagnosis from the to find small ocular melanoma days? Are we still kind of there clinically, or are there advances?
I think there are a lot of challenges in determining what is or isn't a melanoma when we're dealing with small lesions. And I'm
Right.
sure Basil has excellent things to contribute to this as well, but it's not as simple as a clinical algorithm. We use these things to try to guide our decision making, but we have other tools now that we can use also. We can use prognostic biopsies, but again, we assume that something is a melanoma when we're doing that. So a lot of this really is hanging on our clinical judgment. I suspect that within the next 5 to 10 years, we're going to have much more objective methods for diagnosing these tumors. Things like potentially looking at cell-free DNA in fluids like blood or aqueous that are really going to give us an objective answer of is this a cancer or not. But it's much more difficult than cancers elsewhere in the body, where we can take a big chunk of tissue and get a definitive answer. And we're constantly balancing the threat to life that is very real with uveal melanoma with the devastating vision loss that often comes from these treatments. So I think we're going to make molecular advances. I think AI is probably going to help uncover things that we as humans simply can't perceive. But we're very much in the process of these changes.
Yeah, I would agree. I think, we are still using a lot of imaging to try and aid in our diagnostics. And I think when we talk with medical oncologists, it's very interesting because ocular oncology is one of the few areas in which you make a diagnosis of cancer based purely on clinical exam. And when we work with medical oncologists or radiation oncologists for various conditions, a lot of times they will want pathologic evidence to confirm that the diagnosis is correct before they are able to assist in treatment. And so for the things that we control treatment for, like a uveal melanoma, for instance, we are going on that clinical judgment, which the COMS trial has shown is highly accurate. And that's the case, in most of our clinical practices. But I completely agree with Dr. Dalvin that as time goes on, our diagnostic approaches are going to continue to improve. I think, we are utilizing biopsy of these intraocular tumors more and more. I'd say 30 years or 40 years ago, we were really concerned about extraocular extension, or bringing the tumor outside the eye with the biopsy. We were really concerned about a lot of the other potential side effects. And we have learned from uveal melanoma and other conditions that with the appropriate technique and appropriate safeguards, we're now able to do this in a safe way, which is good for patients. And we're utilizing this more and more. Again, right now, mostly for molecular prognostication and understanding outcomes for patients in the future. But as we do this for smaller and smaller lesions, we will have a better understanding of what happens with these lesions, the evolution over time, what that means about whether or not something is or isn't a melanoma. And so there's so many things that we have to learn. But I do think that we are getting better by leaps and bounds, especially as the decades go on.
Before we talk about the next step in treatment, I just want to take one step back in screening. My relative who recently had a melanoma care, thanks to Dr. Dalvin, has hope and life, joy back through that journey. But his diagnosis was based on a screening at a primary care office that had been not performing dilated eye exams for a certain period of time, and then had a fundus image done as a screening tool for their care.
Wow.
In the age of adults that are at risk for retinal disease, uveal melanoma in particular, how often should a primary care office suggest, no, I need to dilate you? And how sufficient is the current wide angle technology for imaging appropriate to be the main role in ruling out retinal disease?
Yeah, I think that's a fantastic question, and I think that depends on a few factors. So we are probably making the diagnosis of some of these tumors at an earlier stage than we would have been before, because we have ultra wide field cameras in a lot of primary care offices, primary eye care offices. I think that's actually critical. And on these general images, we're probably getting close to 80% of the retina and visible choroid in those photos. So if you have a small ciliary body lesion or very far peripheral lesion, it would not likely be identified in those photos. But honestly, if you have a good photographer there, even without dilation, you're able to get such a large percentage of the retina and visible choroid that actually you're able to pick up lesions that you likely wouldn't on many clinical exams. Even if you do retina exams on a somewhat regular basis, it may be difficult to get good peripheral views. And so the fundus camera, ultra wide field cameras can pick up a lot of lesions that sometimes primary eye care practitioners would not be able to identify. So I think that's actually huge in today's times in terms of identifying these lesions. I think this is something that we should be getting dilated exams on a regular basis, on an annual basis when we're in this age range. And I would actually recommend that these photographs be taken on an annual basis as well.
Appreciate that.
Yeah, I completely agree. I think even though we do really great dilated exams, I think sometimes these cameras capture things that the exam does not. So I wouldn't necessarily use the photograph as a replacement for a dilated exam, but I think that it can be a nice ancillary test. And I have definitely noticed an increase in referrals related to findings on a wide field fundus photo.
A lot of our listeners are comprehensive ophthalmologists, and so going through, I'm sure you guys get tons of referrals for mass rule out uveal melanoma, nevus versus melanoma, all those kinds of things. Besides, getting your imaging, getting an OCT, maybe a B-scan if they have the ability to do that at their comprehensive ophthalmology office, what other things do you recommend before they can monitor the patient or really should refer it to an oncologist?
It's a great question. It depends a little bit on their comfort level. The number one most important thing they can do, though, is get that photo and get it early. That way, if they think in the future that maybe this lesion has changed or grown, they can send me that photo and we can objectively decide, is this an urgent referral? So these days, when we have a busy practice where we have difficulty potentially getting patients in who have non-urgent problems, I ask all my referring providers, if you took a photo, send that to me and I will review those photos and make sure that we're going to see that patient in a time-appropriate fashion. I think those photos ultimately are eventually going to be plugged into AI algorithms that provide assisted triage tools that can actually help a primary eye care provider know, is this a low-risk lesion that might be monitored, or do we need to get this patient to an ocular oncologist quickly?
Fantastic.
Yeah, I think your comment, Dr. Dalvin, about the photos is one of the most critical things, because you were mentioning, that it shouldn't replace a good dilated exam, and I 100% agree with that. I think there are two ways in which the photo can be particularly helpful, though. Number one, tracking things over time. So we may be able to do a great dilated exam and identify a lesion, and at that time think that it does not have high-risk features for growth or for conversion to a melanoma. But when we see the patient a year later, how well are we going to be able to remember the size and dimensions of that lesion? And by being able to compare it to a previous photo, it will make a huge difference to understand if there's any progression at that time. And the second thing, I think, is for patient education, to be able to show a patient what something looks like on a photograph, gives them a better understanding of what's going on. And so I think the photographs are particularly helpful in both of those scenarios. And so, again, a combination of a lot of imaging modalities will help determine if something is high risk. But I completely agree with Dr. Dalvin that being able to share a photo, you can talk over some of the characteristics on the photograph to determine whether or not a lesion is risky or concerning. And so much of this is based on comfort, how many of them you see. But if a lesion has low risk characteristics, is relatively small, is relatively flat, does not have any concerning features, I think continuing to follow that for a comprehensive ophthalmologist makes sense. But knowing the people in your area who are practicing ocular oncology, the retina specialists in the area who may be more comfortable with those images, I think kind of having good relationships with them to share the images back and forth can kind of help as well.
Lauren, why don't you share with us just the big picture of then, once you have confidence that a lesion is likely a melanoma, what is the treatment paradigm? What are the common options, whether it's a enucleation, a plaque, or how is that decision tree approached with a patient?
This is a very individualized conversation, as I think is most anything with cancer. So number one, when I'm seeing patients, I really like to try to get scans of the rest of their body very quickly to make sure that we don't see any signs of cancer elsewhere. And that's very unusual that we do on an initial diagnosis, but that gives the patient a big sigh of relief, and then they are much more ready to have this conversation about how we're going to treat the eye. In terms of treating the eye, for me, if we have small, medium, and some large melanomas, radiation is usually going to be where I go. If we have a very large tumor where I know that we're not going to have good visual potential, then removal of the eye may be the easiest option. For radiation, we have a few different modalities. The two that I use primarily are plaque radiation and proton beam irradiation. And I often have really detailed discussions with patients because we have some different dose distribution with these different types that might potentially offer some visual acuity benefit depending on where the tumor is located and how big it is. So sometimes there's really potentially a better choice for that patient long term between these options. For very small tumors, I have this debate all the time, and I don't know if Basil will have some opinions on this as well, but I still have patients to this day who have read online that you can do lasers like TTT laser or photodynamic therapy laser for small tumors, and some patients really, really want that because potentially you avoid some vision-threatening side effects that come with radiation. For me, I really don't like to rely on those as treatment when I believe something is actually a cancer, because they just don't work that well. About 20% of the time, something's going to fail or recur, and you're especially at risk for very late recurrences that can potentially increase metastatic risk in these patients. But there are some clinical trials, things like nanoparticle therapies combined with laser, that results are still out on, but potentially may offer some better vision preservation with higher efficacy than old lasers.
Yeah, I think that's a wonderful layout. I kind of do the same process. I'm thinking between enucleation and radiation most of the time. Dr. Dalvin mentioned clinical trials, and there are a couple of clinical trials that are available for treatment consideration. She mentioned nanoparticle technology. And so for some of the small lesions, and this is kind of often in a category of lesions where we're not 100% sure it's a melanoma or it's likely a small melanoma, you could consider a clinical trial which may reduce the risk of vision damage or vision threatening treatment for those lesions. And then on the opposite end of the spectrum, there's consideration of medication to reduce the size of a tumor that was for a patient that was scheduled for enucleation. So you might be able to avoid enucleation. And so I think really on the ends of the spectrum are where I'm considering clinical trials. Otherwise, I'm talking mostly about enucleation or various radiation options. I also agree, like Dr. Dalvin, I rarely consider laser treatment for these patients. There are some specific situations in which I think it could be worthwhile, but I really have the conversation with them about the risk of a malignancy and the potential for metastatic disease and what we know about local control. And with local recurrence, there's a potential increased risk of metastasis down the road. And so I kind of just lay out all of those options, and most of the time, the patient is easily able to make the decision as to what they think is the most appropriate treatment. And the vast majority of time, we're in complete alignment on that.
I love that it's a patient-specific discussion and they can kind of choose, and you're doing it together as a team, which is great. That's why you guys are the oncologists. Fantastic. So let's say you do choose enucleation. You're able to finally get some tissue. What are the new advances in terms of testing we can do for prognosis, metastatic potential? Like, what kinds of new things are you guys doing? And is there anything on the horizon that's exciting for treatments?
I think fortunately, we're in a place now where it's not only the tumors that are large enough for enucleation, where we have the opportunity to get a sample of the tumor tissue and get a better idea of where we stand for molecular prognostication. I think, we started out with enucleation specimens and taking pieces of those tumors and looking at analyses of those, whether or not you look at DNA or RNA, chromosomal analysis, or gene expression profile. And that gives us a good idea of what the likelihood of metastatic disease is in the future. And I think that is something that has now been translated to intraocular tumors and even honestly very small tumors. In some situations, tumors as small as 2 millimeters or less. Even sometimes potentially within the arcades and the macula area, you're still able to get a sample of those tumors in some situations to let patients know, well, based on the mutational characteristics of this lesion, there is an X percentage chance of metastasis in the future. And I think right now, most of our planning goes around how often we need to surveil them. And that way we can potentially find metastatic disease at an earlier stage. There have been some clinical trials and will be again soon some clinical trials where if a patient has a high risk of metastatic disease, but no actual clinically or imaging identifiable disease at this time, we might be able to enroll them in a clinical trial to reduce the risk of metastasis for the future. And I think that's something that's exciting because for a long time, if we said a person had a high risk of metastatic disease, we didn't necessarily have something to offer them except letting them know that they have a high risk and that we'll scan them more frequently. So I think some of the recent trials and some of the future trials to reduce that risk is going to make a big difference from a mental, emotional, and psychological standpoint for these patients as well.
Sure.
Yeah, I completely agree. I think it's very important to understand it doesn't have to be a big tumor to get this critical prognostic information. And definitely, I think this time in the next 10 years, we're going to see a big boon in these clinical trials that are hopefully going to find drugs that are effective in prevention of metastatic disease. And I think biopsy is going to continue to remain our ground truth for prognostic testing, but I do see some things on the horizon. People are looking at liquid biopsies again. Can we look at aqueous, vitreous blood and potentially get similar prognostic information without putting the patient at risk of actually going into the tumor? And that could potentially pose a little less risk to vision, especially with macular location and small tumors. And then we're also, again, training AI models. So we may be able to even use fundus photos to pick up on features that can provide similar prognostic information. But again, we need these biopsies right now to get the ground truth so that we can train these things for the future.
It's wonderful to hear about what's coming. Other research, I know, Dr. Dalvin, your lab here is quite active in this field. Share with us some of the things you see coming, or you're part of bringing those to the care involved in your lab or around the country.
Yeah, I'm very passionate about research, as you all know. So my patients are mostly all happy to enroll in this big prospective database, and then many of them who unfortunately have larger tumors or develop metastasis have donated tissue to our lab so that we've been able to generate patient-derived organoids, which are essentially little three-dimensional mini tumors that we can grow in a dish. And so we can use those in a really, really tiny format to test drugs on a much faster basis than we could in humans and without exposing them to side effect risk. And we can test them both in the dish and also in animal models. We can create uveal melanoma. We can watch it progress to metastatic disease. And so we can test at every level. Can we treat the primary tumor? Can we treat the metastasis? And can we prevent progression? And so I'm very hopeful that we're going to eventually discover some drugs that can be used. And then we're going to be able to use this workflow for personalized medicine strategies, where I can actually take a sample from a patient and feed back to them in just a matter of weeks. This is the drug in our panel that is going to work most effectively for you.
So I know, Dr. Dalvin has done a great job of mentioning both liquid biopsy and artificial intelligence using imaging modalities. This is not only helpful for diagnosis and prognosis, but perhaps by using biopsies to understand mutational profiles in tumors. There's already work going on now with medical oncologists and ocular oncologists together to look at different target points along people's individual mutational profiles and choose medications based on that. Perhaps AI will be able to pick up some of those things that we can't see clinically, and that will be something that's helpful. So I think there's a lot of things that are going on right now in multi-center collaborations that will hopefully help, but I think the organoid research is definitely among the things that are going to be shaping the future of personalized medicine for these patients.
I just want to call out that you said multi-center collaboration. I think that is so critical for our field, for any field dealing with a rare disease. We absolutely have to work together. And so I think gone are the days when we think this is the head honcho in the field, this is the person who does everything alone. We are all a team, and we all need to collaborate to really push the field forward.
What a perfect summary for a multi-location, multiple experts at the table podcast today. So I just want to say thank you for sharing your spark, your insight, your passion, your perspective, and wisdom with us today on this podcast.
Yep, and thank you for caring for these patients. Great job, you guys.
Much appreciated. Thanks for having us.
Thank you so much.
Thanks, Faisal. Thanks, Lauren. You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more